We spent 6 episodes talking about road rage, and we now know that people with high trait anger and those with intermittent and explosive disorder are among the most susceptible to engaging in road rage. As I said before, I'm going to dive into treatment approaches for both, not just because I'm curious as a mental health counselor, but also because the people who prompted me to start this anger translating theme might benefit from this information. Please note that nothing on this channel constitutes professional advice. I'm simply sharing information that is already publicly available. Let's start with treatment approach for people with IED. IED, or intermittent explosive disorder, is a psychiatric condition characterized by recurrent, impulsive outbursts of aggression that are disproportionate to the situation and not premeditated. These episodes are typically brief, driven by a failure of impulse control, and often followed by regret or distress. IED is a clinical disorder and requires clinical treatment. The research here is consistent and increasingly specific. First, CBT is the best supported first-line treatment. Evidence from randomized trials and meta-analytic work shows that CBT significantly reduces aggression and in some cases can lead to remission. The most supported techniques include relaxation training to interrupt physiological escalation, cognitive restructuring to challenge hostile interpretations, and skills training focused on impulse control and emotional regulation. Next, medication can be useful, but it's not a standalone solution. There are currently no FDA-approved medications specifically for IED. However, SSRIs, particularly Fluoxetine, have shown meaningful benefits. A randomized controlled trial by Coccaro, a psychiatrist at the University of Chicago, best known for his research on intermittent explosive disorder and impulsive aggression, and his colleagues found that fluoxetine significantly reduced impulsive aggression, with a substantial proportion of patients showing full or partial remission. SSRIs appear especially helpful for reducing the baseline irritability that contributes to explosive episodes, even if they do not eliminate them entirely. Mood stabilizers such as lithium, valproic acid, and oxcarbazepine are also used off-label. Evidence suggests that combining CBT with medication often produces better outcomes than either approach alone. Third, a critical point about seeking help is that IED is often underdiagnosed and undertreated. Many people interpret explosive behavior as a personality issue rather than a treatable condition. As Coccaro has pointed out, people often see this as a bad behavior they have developed over time. In reality, it has significant biological and neurological components. That distinction matters, because conditions with biological underpinnings also have treatment pathways. Shame and self-blame are not effective treatments. Professional assessment is. There are shared tools for both IED and high trait anger, and I'll cover them at the end of this episode. Now let's turn to treatment approach for people with high trait anger. High trait anger is not a disorder. It is a personality disposition. This means that it's generally workable without clinical intervention, although professional support can escalate progress. First, CBT is the best supported starting point. It's the most extensively studied psychological intervention for trait anger. It helps people recognize the early signs of angry arousal, identify the thought patterns driving it, and develop alternative responses before the reaction escalates. Common patterns include hostile attribution, catastrophizing, and entitlement beliefs. Meta-analytic research shows that CBT-informed anger management can meaningfully reduce both the frequency and intensity of anger, while also improving self-esteem. One important caveat is that attendance matters. People who complete a full course tend to benefit significantly more than those who drop out early. Next, relaxation and physiological regulation are also core components. CBT for anger regularly includes techniques like diaphragmatic breathing, progressive muscle relaxation, and mindfulness meditation. This is because anger is not only a thought pattern, but also a physiological state. Lowering physiological arousal can raise the threshold for anger responses and reduce reactivity. These skills can be practiced outside of therapy and applied in real time. Some can be used while driving. In fact, I did a full episode on in-the-moment anger management tools for driving. It's titled Calm Road Rage Fast. Check it out if you're interested. Cognitive reappraisal is worth highlighting on its own. Reappraisal involves actively changing how you interpret an event before the emotional response fully escalates. For example, instead of thinking, that driver cut me off on purpose, you might think, they may not have seen me, or they could be having a difficult day. This is not denial. It's engaging prefrontal regulation before the emotional response intensifies. Next, we have acceptance and commitment therapy, or ACT. It offers a complementary approach. While CBT focuses on changing thought content, ACT focuses on changing your relationship to your thoughts. Instead of arguing with angry thoughts, ACT teaches cognitive diffusion, which means observing a thought without being driven by it. Saying, I notice I'm having the thought that this person is an idiot, creates distance from the reaction. That distance can be enough to shift from automatic reaction to intentional choice. Now we come to shared tools. Exercise is one of them. Regular physical activity improves mood regulation, reduces baseline stress, and is associated with lower levels of trait anger and aggressive behavior. It also provides a physical outlet for the arousal that anger generates, without directing that energy toward another person. Another tool is the Pennebaker method, or structured expressive writing, which we've covered before. This involves writing about specific frustrations, perceived injustice, and accumulated disappointments over multiple days. Research shows that expressive writing can improve emotional processing and reduce distress, with some evidence suggesting modest reductions in anger-related outcomes. Writing helps organize and process the underlying emotional experience. Concepts from contemplative traditions can also support anger regulation, and they map well onto evidence-based psychological strategies. I already introduced the second arrow and the rain practice in the episode Calm Road Rage Fast. These two apply to both high trait anger and IED. The idea of second arrow is this. The first arrow is the triggering event. The second arrow is everything your mind does afterward, including rumination, imagined retaliation, and escalating internal narratives. The most important thing to know is that the second arrow is shot at oneself, and it often sustains and amplifies the emotional response long after the initial trigger has passed. Practices like RAIN, which stands for Recognize, Allow, Investigate, and Nurture, provide a structured way to interrupt that process. Thich Nhat Hanh's Going Home practice offers a simple and practical intervention. When anger arises, the instruction is to return attention to the breath and the body, and to ground yourself with a short, internal script. For example, you might gently say to yourself, I am here. I am breathing. I do not need to follow this anger right now. This is particularly relevant for IED, where the window for intervention can be very brief. The goal is not suppressing rising anger, but creating even a small gap between the trigger and the response. The Taoist concept of pu, meaning uncarved block, is especially relevant for high trait anger. It refers to approaching each moment with minimal preconception and greater openness. People with chronic anger often expect hostility and then interpret events through that lens. This can lead them to behave in ways that increase the likelihood of conflict and elicit hostile responses from others. Practicing pu means deliberately loosening those expectations and allowing for alternative interpretations. This is a gradual process, but it can begin today with a simple question. Can I approach this moment without assuming I already know how it'll unfold? If you find this useful, hit like and subscribe. And thank you. Your curiosity and willingness to translate anger are received and appreciated.